Welcome to Interdisciplinary Case Miles, a podcast where real runner stories meet clinical expertise. We discuss real cases that are anything from weekend warriors all the way to elite athletes, while using our evidence-informed approach.
I'm Dr. Sarah Reiser, a running medicine physician focusing on helping runners prevent and recover from running-related injuries while optimizing health and performance.
I'm Kelsey Pontius, a sports dietitian helping runners to fuel smarter, recover better, and help avoid the risk of injury so that they can meet their goals.
And I'm Dr. Kate Mihevik-Edwards. I'm a physical therapist and orthopedic specialist, and I've been treating for runners for over 15 years. And what I do is help them get back stronger and better. We're excited about this particular case, and we were kind of, beforehand we were talking and laughing about this. This could go so many different ways because it's such a cool case, and it's something that happens enough, but it's when it happens, people really don't know what to do about it. So the case that we're talking about today is a navicular bone stress injury. So if you don't know where the navicular is in your body, by the way, it is in your foot. And so it is on the, if you're looking at your foot, it's kind of on the inside portion of your foot, okay? And when you're rolling in, you load that part of your foot. Can you stop that, baby? Okay, I'm going to say it again. So, sorry, guys. So if you guys don't know where the navicular is, it is on the inside part of your foot, and that's where we're going to be addressing today. So this particular case is a track and field athlete. So this athlete does 400-meter runs, and she also does a long jump. It's a female athlete, and she is a sophomore in high school. And so she presented to me after she's had this bone stress injury for quite a long time. So it was probably almost a year later by the time I saw her, because she had been diagnosed with a bone stress injury. She went through what she thought was typical treatment for it. And then for the next 6 months or so, she was off and on. So she could run a little bit, do a little bit, and then she had to back off again. And then she thought she was in the clear and it would happen again. And so she was getting really frustrated, and her parents were really frustrated for her. Something about this case is her parents were incredible and they really wanted to support her, but they didn't really know anything about running. And so this athlete actually had some low energy availability as well. And that's probably part of what preceded the bone stress injury, but she was not doing it intentionally at all. And part of it was because she didn't realize, and her parents didn't realize, how much more fuel she needed based on all the training that she was doing. So I'm going to pass this off to Sarah so that you can talk a little bit about what is a navicular bone stress injury? Why is it different than somewhere else in the body? And what do we need to do from a physician standpoint?
So this is already a loaded case. What I like to talk about with the navicular, I always talk about this perfect storm for bone stress injuries. So there's some component that contributes to the development of bone stress injury involving nutrition, biomechanics, and training loads. And generally, all of these things are involved when it comes to navicular. Oftentimes there's anatomical components, and then you have folks who have higher loads, so a lot more jumping. So sprinters, jumpers, basketball players, a lot of those different athletes are going to be at higher risk for these injuries. And oftentimes these folks will have high arches as well. So there's, folks that they walk in the door and you already have an idea of where they could potentially have an injury. Then they point to their midfoot and you go, oh no. So I think about the navicular as the keystone of the arch, and basically on the other end of the posterior tib. So we get shin splints on one end if there's an issue, and then we can have a navicular injury on the other end. And so many things that can go into this injury, but I think it's really important that there's really good patient education so that the patient understands, number one, this is a critical site and there's a good chance that this thing may not heal, and we have to treat it like it's, very urgent and precious and bubble wrap that thing. And not that we need to be scared of it, but that we really need to make sure we treat it right. Because if we get to the other end and we're a year out and still having pain, the longer we go, the less likely it is to heal. And if we're not seeing usual healing patterns, then we need to throw more things at it. So we might use bone stimulators, shockwave therapy, making sure we're getting Kelsey on board and working on nutrition. So first and foremost for that navicular bone stress injury is that bone heals. There's a watershed zone in the navicular, which means that you may not get great blood supply to certain parts of it. So depending on where you have that bone stress injury, if there's just bone marrow edema, so swelling in the bone, or if there's actually a fracture line, the fracture line is oftentimes the bigger issue, because if you load bear and that stress fracture, if those two pieces of bone actually pull apart, then that's going to make it a lot harder to heal. Plus, then you have the vascular issues. So there's a number of reasons why this doesn't like to heal. But then, of course, we think about that bigger picture of biomechanics, nutrition, and training loads. So tons of patient education with this. This requires a period of total non-weight bearing with healing. So this patient has been through a lot already. So when they get to Kate, oftentimes Kate's going to be talking about the whole big picture, right? So also talking about psychology and sports identity and all these pieces, because a lot of that's been ripped away in the last year. Plus that on again, off again. I always talk to my patients about, I really want to gradually get you back to your activities. I'd much rather not do the big ups and big downs. Like I got back for a week and now I have a big injury again. I'm back for a week, big injury. So it's all got to be slow going, and they should be doing way less than they want to. They should always be kind of itching and, hoping wanting to do more as they're doing that progression back. So really holding them back to some extent, but explaining why that's happening. So much of this, like I said, is patient education and really setting expectations and saying, hey, this is going to be a long haul, but we want to make sure we do it right from the very beginning. So,
Kelsey.
Oh, sorry. Okay, so what I have learned about like different sites of bone stress injury from yours truly, Dr. Sarah Reiser, actually, I learned this from, is that trabecular bones are more porous and metabolically active relative to other bones in the body. And so the fact that the navicular bone is a trabecular bone is very clinically significant from a dietitian's perspective. So if you're a young RD listening, learning these things from other providers is really, really valuable, because I know that wasn't something that I learned in school. And so, it's going to be influenced a lot by whether there was low energy availability that started to create this site as a risk factor, or if it's, starting to impact the rate of healing. And so, of course, in my assessment, I would be using questionnaires like the LEAF-Q, which is the low energy availability questionnaire in female athletes, to look for other signs of underfueling. I think Kate said prior to this case that this athlete was getting her cycle, but even digging deeper than just asking, do you have your cycle, asking when she got her cycle. I think we mentioned that she was a sophomore in high school. And so there's still some growth for female athletes after they start their cycle, not much, but for 2 years after they, for the most part, after they start their cycle, there's still some growth. So even collecting growth charts and looking, was there any stagnation in growth charts? Were there any periods where she stopped growing, that kind of thing. And then asking about like recovery and sleep and length of cycles. And are there any irregularities other than just simply, are you getting a cycle or not? I've learned as a practitioner, when you ask these questions, really educating a teenage athlete around why you're asking these questions and educating them around the role of getting cycles and their trajectory as an athlete and healing and their success in the sport, and the connection between fueling and getting a cycle is really critical. Otherwise, it just feels like a random invasive question. So that education is really, really important. So once I've kind of screened for things like eating disorders, is there any other signs of low energy availability? I think this case was really some involuntary low energy availability. And one thing Kate mentioned was that we have a first generation athlete on our hands. And so she's at the point of school where growth and development is the fastest that it's been in her whole life, with the exception of infancy. So that's clinically significant. So it takes energy just to grow. And then she's running as her sport. And so that is going to place a lot of metabolic needs. And now she has a bone stress injury to heal that is highly metabolic. And so these are things that I'm considering. And so there's some education still needed with the parents of like talking about the fueling needs for all of that. Because they might have an athlete that is small in stature, maybe height, and it's not necessarily clocking for them that they're baby needs 3,000 calories. And then, just the pure opportunity of when she can eat and the opportunity at school, because sometimes these opportunities aren't presenting themselves. And if she needs something around 3,000 calories, just to put a number out there, but I wouldn't be surprised by that figure, then it's going to take more than breakfast, lunch, and dinner to get her there. And traditional snacks, like a bag of goldfish for a snack, not that she can't eat that, but that is 100 calories. So that's not going to close as big of a gap as we need to with snacks. So highlighting all of the places where this athlete can get snacks and avoid any windows of low energy availability, and make sure that she's fueling consistently through these needs for these increased needs that might look a little bit different than her other classmates or maybe even other siblings in the family.
That's great. And, this athlete in particular, and also as a mom with an athlete that eats literally 3 dinners, food can be so stressful, and making sure your child gets enough food can be really stressful. I've found this to be true because he's so hungry all the time. But I know that for this family, it was a similar thing. The parents were really stressed about making sure she had enough. So talking to her, making sure that she was talking to an RD and that they were giving her simple things and ways to get that calorie increase was really, really important. So the snacking, or like making certain things ahead on the weekends and making it part of the family, like you do it together, like it's fun to make. That's what we do at our house. We all cook these things on the weekend together to make sure he has enough to eat. But those things are really important. And so even though I'm obviously not an RD and I send to an RD, I still have to have these conversations with these athletes because it comes up a lot. And I spend a lot more time with these athletes than most people, over an hour, usually. And so that's one thing. The other thing that, we've had athletes together in the past and that struggle because their calorie requirements are so much higher than all of their friends because of the sport that they're in or the build that we have. So, that's something that we struggle with too, Kelsey. And from like a mental emotional standpoint, we have to think about that as providers and being able to talk with them about it. So that really brings the part of, again, for me, it's a lot of education. Like, hey, please talk to the RD. Please talk to your physician, because all of these things are important. And we really want to make it as easy as possible for you. We don't want you to be stressed about these things. And when I got this athlete almost a year out, she was a stress ball. Our homework was, okay, let's just focus on breathing, or let's just focus. She didn't want to meditate. She's a sophomore in high school. Let's go on a short walk where we're thinking about how our feet feel when they hit the ground. We're going to think about what sounds do we hear? What do we see? And just trying to get them more present in their own body. That's part of what I'm trying to do with this kind of athlete in PT. But then, when we're really thinking about this bone stress injury, so the posterior tib actually attaches to the navicular, and posterior tib is one of those muscles that helps to control pronation, and the speed at which we pronate and how our body handles that pronation does impact the navicular. And what Sarah talked about is we want to make sure that the navicular, if there's a stress fracture line, it doesn't pull apart. And so my job as a physical therapist is how are we going to stabilize that foot and ankle enough, and also all the way up the chain to decrease the amount of stress and load at that bone. And one of the things we'll do is we'll do a lot of posterior tib strengthening, a lot of pronation control. We'll talk about rotational stability. So we'll do single leg activities working on rotational stability, working through the foot and ankle itself, and also the arch of the foot. You'll hear me talk about this all of the time. So those are some of the things we'll do. But then with this particular athlete, she was actually really strong because she had done everything she was ever asked to do before she got to me, and she was still having some issues. When it came down to it, I did ask her to get another image to make sure that there was no stress fracture line. So I talked to her physician and said, "Is there any way we could look at this again?" And she didn't have anything. So the pain that she was having was because of everything else that was going on, and some of it was fear. And so we worked through her pelvis and her hip to make sure she was getting better hip extension, and we worked through her ankle so that she got better dorsiflexion, because if your dorsiflexion is lacking, you're going to roll into that pronated position a little bit more. And then we worked on confidence with every single thing that she did. We made sure that she felt good with the exercises that she was doing, and as we were adding plyometrics, because remember, she is a jumper and a 400 meter runner, so she has to have a lot of power and she has to have a lot of dynamic control. But every single thing we did, we worked on confidence. And some of the time that I had her was just talking through confidence and like telling her things that I've told her before, and listening to what she had to say about her fueling, about what was stressing her out at school. And I even asked her to talk to a sports psychologist around like returning to sport, because she was afraid to jump because of this navicular stress fracture, because she did really understand that it was critical. So she didn't really trust her own body. So I had to send her to a sports psychologist to get that figured out.
A couple of things I want to mention from the medical side of these particular injuries. I do often repeat imaging. And one of the biggest reasons is, one of them is confidence, right? So having the athlete feel like, oh, it's on the way, we're making good progress. The other is oftentimes aches and pains start coming up. And the question is this the body just kind of sending these little sensations of this used to hurt? Or is this an injury that's persisting? Are these other soft tissues that are the problem? And so sometimes I say we just lay it to rest. We get the imaging, we see what things look like. MRI imaging, the soonest that I'll repeat it is at 2 months, because you actually have a lag time in terms of the healing process. So you may see some bony edema or swelling in the bone that's persisting, even though clinically the patient may be doing well. So I always also set expectations that it may not look 100% better, but as long as we're on the right trajectory, I'm okay with that. And certainly if someone has a fracture line, that's another conversation too. But I do think oftentimes these require quite a lot of additional follow-up, because I'm trying to figure out, do I reassure them and say this looks good, or oh, we need to take another look at this and make sure that we don't need to take a step back. So I usually follow these people for quite some time, for both the give and take, the reassurance as well of, ooh, maybe we should look at that. The other piece is, if this athlete was non-adolescent and in her second year of competitive running, if this was a collegiate, professional, pro athlete, they may potentially elect to immediately have surgery and have hardware and stabilize the bone. Now, it is a surgery, and you do have the confidence of stability, but at the same time, you also have the risks that come with surgery, and you may also have some achiness and soreness that can stay there because there's hardware and you have procedures. So, it's definitely a give and take of figuring out when that's the right thing. Sometimes it's also something that happens later down the line if folks have recurrent navicular stress fractures or delayed healing. But there are some athletes who will just immediately go straight for that because they want the training time and don't want the downtime. So that's a really big conversation and lots of things to weigh in on that. But another point of why this is such a polarizing location for bone stress injury, because there's so many conversations that need to go into this and figuring out what's best for the athlete.
Yeah. Kelsey, do you have anything else to add?
Yeah, I was just thinking, while Sarah was talking, I'm jumping the gun with nuggets and takeaway nuggets, but I think the stage that an athlete is in matters so much, because we've all, sat as part of the medical team of Atlanta Track Club Elite, and those decisions are much different than a decision that you're making for a high schooler, or even, them, an athlete being in their freshman or sophomore year matters a lot different than how I would maybe treat them and the responsibility I would place on them if it was a junior or senior, someone that has committed to school and they're a senior and about to be in a situation where mom and dad aren't preparing their meals. And so I think that just where an athlete is in their journey just really matters with like what kind of treatment you give them.
Oh my God, absolutely. And if it's like if you're seeing it 2 months in, so from a different perspective, if you're seeing it 2 months in versus a year out, that's a completely different injury and a completely different athlete based on all of the mental and emotional things that have happened, everything they've been doing, the fatigue of the injury. Yeah. So it's so easy to get fatigued when you have an injury that lasts this long, and you can be doing all the right things all of the time, and you're still not where you thought you would be. That can be devastating. All right, ladies, I think it's time to wrap this one up. So, Sarah, why don't you go first? What are your 2 take-home messages?
Yeah, I think the biggest one is patient education is so important here in terms of making the right decision and then also making sure everyone's on the same page so that we can really try to optimize healing and keep that process as short as possible to get patients back to what they want to do.
Great. Kelsey?
Yeah, I think that, just when you're working with a youth athlete or adolescent athlete, just making sure that, what you're educating the athlete on, the parents understand too. And so that the athlete feels like, they have a team.
I love that. And I would say that almost always, just because the injury is in the foot and ankle doesn't mean we don't need to address everything else. And I mean everything else from physical, mental, emotional standpoint, right? So I'm definitely looking up higher at the pelvis. I'm looking at the hip. I'm looking at the knee. And I'm asking about where are you from a confidence standpoint? How are you feeling on a day-to-day level? What's your nervous system like? Do you need to speak to another, mental health provider or something like that? So. All right. Well, thank you so much for listening to us again. We're excited that you're here. If you love this episode, please pass it along to any coaches or friends or running partners. We love that. That's how we're getting bigger and sharing everything. And then also, if you have any questions for us or any case that you want us to dissect, we're always, looking for cases. Send us an email at runcasemiles.com and we will get back to you for sure. And at the very least, and then maybe we will even present your case sometime. So, all right. Thanks, guys. Talk soon.
Bye.